Welcome to AETCM, the emergency medicine channel.
Yes.
So, shall I start? Presenting the case of a 25-year-old male who presented to ER with exposure to electric shock from a 220 volt switch while trying to switch on the fan in his room about half an hour before arrival to ER. And he is also complaining of paresthesia over the both sides of face and also right upper lip. And on initial 10-second assessment, patient was conscious oriented. He was obeying to commands, and we initially checked the C-spine. C-spine was normal, and cardiac monitors were attached. And on primary survey, the airway was patent. There was no pooling of secretions or gurgling of sounds. He was able to complete talk in full complete sentences. And breathing, the patient had a saturation of 99% in room air with a respiratory rate of 18 per minute. And airway was bilaterally equal, and there was no presence of any added sounds. Circulation, the heart rate was 86 per minute with a BP of 120/80 millimeters of mercury, and all peripheral pulses were felt, and it was equal. And the disability, the GCS was E4, V5, M6, and pupils were equal and reactive of size of 2 mm, and patient was moving all 4 limbs. And the exposure, the patient had a temperature of 97.2 degree Fahrenheit, and there was the presence of a minor entry wound of about 1 into 1 centimeter on the right thumb, the ventral aspect.
And what else you see when you are seeing an entry wound?
Look for the exit wound.
So that is very important. If there is an entry and exit, then the damage will be more severe sometimes.
Exit wound is not identified.
Okay.
And pain score, patient had a pain score of 6 out of 10. So we just had given an injection, paracetamol, one maybe status scheme. And
what is the importance of pain in emergency room? This is the fifth vital sign of the patient. You are seeing pulse, BP, temperature. What is the third one? Saturation. Okay.
Yeah.
Then next is pain. Any patient come to emergency room due to pain, whatever may be the reason. The first thing we have to control is pain. Okay. If you don't control pain, what all things can happen? If the pain persists in a person, what all things can happen? Why we are more worried about pain?
Pain can increase further the sympathetic response.
So what like
in the heart rate.
Then it's a stressful condition. Your BP will increase, your heart rate will increase, your ejection fraction will come down, your sugar will increase, your stress hormones will increase. So everything is going to increase. Every problem in your body, whether you have fever, a myocardial infarction, stroke, everything is going to deteriorate. So pain management is a very important thing in emergency room. So whoever comes with pain, manage pain first, then find out what is the reason.
Yes. And patient, then we moved on to the adjuncts to the primary survey. We took an initial ECG showing a normal sinus rhythm with a QTC of around 410. And VBG was
410. Yeah. 4 is no 410.
Yes. And patient showing having VBG showing no acidosis.
What are the ECG changes for electric shock?
In electric shock, most probably there will be a possibility of a ventricular fibrillation. Can be arrhythmias is
VT. Okay, ventricular fibrillation, VT, both are possible. Okay, yes. Acutely. When you get the shock, but we don't see that. No. Most of the time we get the patient after some time.
Then there's possibility.
Why are we taking ECG?
Will it look for the hyperkalemia changes
immediately?
No.
Do you think that immediately after shock hyperkalemia occur and that produces ECG changes? No. What are we looking for?
Conduction.
Okay, conduction defects are one possibility. Yes. We can get conduction defects. Heart blocks. Then VPCs. Okay. Whenever there is myocardial injury, you can get ventricular premature
or
bleeds.
an acute myocardial injury.
Myocardial injury is most important. Many patients with shock, like you give defibrillation or DC cardioversion. After that, if you take ECG, you can see ST elevation, ST depression, rapid tachycardia, everything. So myocardial injury is most important after an electric shock. So they can present with tachycardia, bradycardia, ST elevation, ST depression, everything.
Yes. And we are taking a VBG showing no acidosis or alkalosis, pH of 7.42, and bicarb of 24, lactate of 1.2, and creat of 0.6. Yeah, potassium of 3.5. And moving to sample history, the patient was a 25-year-old male, no known comorphs. He presented to ER with a history of an exposure to an electric shock from a 220-volt switch while he was trying to switch on the fan in his room half an hour back before arrival, and patient had complaint of paresthesia of both halves of side of face, along with he had paresthesia on the right upper limb. And there is no history of any palpitation or any chest pain or any dyspnea on exertion history or any history of any giddiness episodes. No history of any loss of consciousness or no history of any acute onset disorientation or any weakness of limbs or slurring of speech. There is no history of any headache, vomiting, or there is no history of any seizure or pain along the neck. Then there is no history of any blurring of vision or hearing loss. And
why you are asking blurring of vision?
In acute electric shock, patient can have associated corneal injuries, corneal abrasion.
Okay. Chronic electric shock. What is a common finding? Chronic electric shock.
Retinal hemorrhages.
Retinal hemorrhage.
Or
Cataract.
Cataract, sir. Cataract.
Cataract is the most important problem of chronic electricians. Chronic electric shock.
And there's no history of any pain over the shoulder region. And patient usually if patients get an electric shock, there's a increased chance of posterior dislocation.
Shoulder. Because when the sudden violent movement of hand, dislocations are more common.
Yes. And then this patient was not thrown back or stuck to the switch. And there is no history of any abdominal pain or vomiting, and no history of any discoloration of the limbs. And allergic history, the patient is not allergic to any drugs, and medication history is not having not using any medication. Past history also nil, significant, and the last meal was taken 2 hours back. On arrival, on examination, patient was conscious oriented. General examination, there was no presence of any pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. And CNS, his power was 5/5 of all 4 limbs, and all sensations were intact. And CVS S1 S2 was normal. There was no presence of any adhesion murmur present, and chest it was clear.
You expect murmur or something else?
Irregularity in the rhythm.
You expect murmur or something else? How many? He's expecting a murmur. How do you get a murmur in electric shock? S3 is a cardiac failure. S3 can be there. Not murmur. I don't think you get a valve prolapse or valve rupture in electric shock. Maybe severe electric shock. I don't know. Not sure.
And chest was clear, air entry was bilaterally equal, there was no presence of any added sounds. Per abdomen was soft, and there was no presence of any external injury in the abdomen.
Okay.
And we had done the routine blood investigations, showing a total CK value of 91.
So one investigation is CK, creatine kinase, and CKMB.
Yes.
These 2 investigations we have to check in all patients. Then some patients we can look for potassium, creatinine, all these things. Rhabdomyolysis, renal failure. These are the 4 major investigations you do in electric shock.
And after that, we had also done urine routine. It was showing normal. And
we are doing urine routine.
Presence of urine myoglobin. Myoglobin expecting. Patient also had potassium of 3.5 in the lab. And
so it's only a mild shock.
And we are patient had symptoms of paresthesia, so that's why we are admitted.
You know something called as burn percentage. We may learn in burns.
Yes.
Electric shock is also burning.
Yes.
Can we take that burn percentage here and apply it here?
No.
So here skin area may not be burned.
Yes.
It's all muscles and internal tissues, bones, everything.
Yes.
So it is very difficult to assess the amount of burn in this type of patients. Okay.
So in this patient, he was kept under observation,
Okay.
and his symptoms, he had like hydrated him with IV fluids.
Okay.
So initially itself on
What
arrival,
is the need of hydration in this type of patients?
patients can have a muscle injury associated.
Rhabdomyolysis, myoglobinuria, kidney failure. Then you have to give more fluids to remove that myoglobin.
Yes.
Otherwise, hydration may not be useful, but still we have to give because we don't know when the patient is going to develop all these problems.
Yes. And after that, we have kept him on observation for 1 day. Then he is symptomatically better. It was discharged.
Okay.
And moving on to electrical injuries. Electrical injuries are usually divided into high voltage or low voltage injuries. High voltage is usually if it's more than or equal to 1000 volts, and low voltage usually if it's less than 1000 volt. And also there's presence of electrical arc flash burns,
Okay.
which do not result in the passage of current through the tissues. And bone is the tissue which is having the greatest resistance. And also nerves and vascular structures have low resistance, so they are more prone to injury. And dry skin has high resistance, and wet skin has low resistance, so more susceptible for electrical injuries. And AC current is more dangerous than DC current, because the AC current, the fluctuation of the cyclical variation of the alternating current can cause ventricular fibrillation. And AC current can also cause muscle tetany. So muscle tetany can lead to the hand getting stuck to the site of the shock, and victim cannot let go of the hand.
So normally, if you touch like this, the hand will be thrown away. If you touch like this, you will grasp it. It is like that. So that's why they always touch like this to know whether electricity is there or not.
And risk for a serious or fatal injury increases with the voltage, especially if the voltage is more than 600 volts. So the risk is more higher then. And electrical induced injury is by 3 mechanisms. The first mechanism is by direct tissue damage from the site of the electric shock, and the second one is the tissue damage due to the thermal energy produced by the electric current, and mechanical trauma faced by the fall of the patient following the electrical shock. And the clinical features, usually patient can develop cardiac injury. Cardiac injury is usually in the form of arrhythmias. Most common case will be in ventricular fibrillation or asystole can be usually seen. Or patient can be asymptomatic with normal ECG. If patient is asymptomatic with normal ECG, he is having less chance to further occur any changes in ECG in further hospital stay. And MI can also occur, along with patient can also occur thrombosis or dissection of the aorta can also occur, and conduction blocks are also possible. And patient usually CNS spinal cord injury can also occur in such patients. In CNS, transient LOC is usually most common in such cases, along followed by seizures. Seizures is also a possibility. Patient can also be in the form of a confused state or comatose state. In such states, patient must require initially airway protection must be initially needed. And the focal neurological deficit patient can present as paraplegia or hemiplegia, or quadriplegia. And usually patient can have aphasia or visual disturbances also associated. And if patient was thrown out from the site of the injury, patient can have a C-spine or like secondary traumatic brain injury. So in such individuals, neuroimaging is and like spinal and head CT imaging is also necessary. If patient is getting an occipital lobe injury, patient can have a chance of blindness. And the peripheral nerves usually mostly get involved. They can involve
the symptoms difference between occipital lobe injury, blindness, and frontal lobe or anterior area injury and posterior lobe area injury. What is the difference in blindness?
Blindness.
Suppose your anterior part of the circulation is damaged and the patient develops blindness. And posterior circulation loss, blindness. What is the difference?
Macular.
Anterior usually has this vertical.
Don't tell new theories. What is the importance of pupil? So Somebody is saying, like he told, posterior injury causes visual loss. He tells visual loss. You check the pupil, what will happen? Fully dilated. Have you learned about Edinger-Westphal nucleus? What is that?
Midbrain.
In the midbrain. It will never go to the posterior circulation. It goes like this and come like this. So you put a torch. Normally you get pupillary construction. In a blind person, anterior problem, you put a torch, you don't see any pupillary construction because his anterior part of the vision is completely lost, either optic nerve, optic chiasm, whatever it is. But posterior circulation is nothing to do with the Edinger-Westphal nucleus. So that is paired. So you put a torch, you can see the same side and opposite side will be reacting. So that's how we differentiate posterior blindness and anterior blindness. Okay. Cortical blindness and peripheral blindness.
And spinal cord injury can also occur. Usually it could be a vascular injury, maybe due to the affecting the spinal artery, or it can also be due to a membrane damage also.
How do you differentiate anterior spinal artery and posterior spinal artery injuries? It's a part of trauma ATLS training, no? Anterior spinal artery injury, posterior spinal artery injury, anterior cord syndrome, posterior cord syndrome. That all comes under ATL.
Yes, sir. Anterior will be mostly present with muscular the weakness. Anterior horn
theories you are telling. You have to tell. Finally,
pyramidal tract mostly anterior spine.
Anterior cord syndrome, posterior cord syndrome. Very simple question.
Anterior spinal artery and posterior spinal artery. If anterior spinal artery is involved, spinothalamic tract and the pyramidal tract will be involved. Posterior means descending tract is the
involves the posterior column.
Posterior
How do you differentiate? Anterior spinal artery, you get weakness. That is correct.
Yes.
Posterior spinal artery, you don't get weakness. Okay, but what else will be there in this patient? Anterior spinal artery, pain and temperature loss. Posterior spinal artery,
pressure and proprioception.
Okay, so that is the main difference. So that's why you differentiate anterior spinal cord syndrome, posterior spinal cord syndrome. There are two syndromes in trauma. Okay, so that you have to differentiate means you have to check the pain and temperature loss and vibration and joint position sense. Okay, so one is taken care by
the
spinothalamic tract. Other one is
by the posterior
column. Okay. So nothing to related to this. It's a trauma related question, but here also it is a trauma.
Yes, sir. And cutaneous burns can occur usually in the region of the electric contact areas. So in case of DC current, usually patient will have an entry and exit wound. But in AC current, there will be only presence of the burns around the contact area. And usually the injury will be typically painless. Along with usually its color changes from grey to yellow, and there will be depression in that area on the site of the contact.
This patient had.
Yeah, this patient had. And orthopedic injuries can also occur because patient will be thrown away. Associated fracture can be occur due to the tetanus muscle contractions or shoulder dislocation.
Dislocation or tetany?
Tetany.
Not tetanus.
No,
tetanus is a different disease.
Tetany.
Okay, severe muscle contraction is tetany.
Yes.
You should use words properly.
Yes. And patient can also occur ocular injuries. As in the case of cornea, there can be presence of epithelial erosion, keratitis. In chronic condition, patients having an electric shock, they will develop cataract. And along with that, retinal detachment and optic nerve damage are the various sequelae which follows. And auditory tympanic membrane hemorrhage can also occur. And the GI injury also can occur. Patient can develop bowel perforations and intra-abdominal hemorrhage. And usually before in the scene and pre-hospital area, we should do the pre-hospital care at the site of the where the electric shock is, which has occurred. If patient is found unconscious in an area of electric shock, or in such areas, initially we must switch off the main electric supply of that area, and we must initially before switching off we must stay at least 10 meter away from the area of the electrical source. And if the
what is scene safety in
yes.
first aid? What is scene safety? This one.
Yes, so initially
The
we must
patient
maintain.
had got electrical shock. First of all, you have to diffuse the electricity without getting damage, like harm to you.
Yes, and we must wear gloves and shoes which is rated for the power line voltage according to the area. And if sometimes the patient can go into an apnea with presence of pulse. So that apnea, so we must provide rescue breaths for patients to revive the patient. And we must also maintain a spinal immobilization of the injured patient if possible. And low voltage AC current usually produces ventricular fibrillation, and high voltage AC current can produce a ventricular arrest. And and assessment and treatment, the circulatory factors usually we treat by the Parkland formula. Parkland formula in case of
Parkland formula, the problem is we have already discussed now. Parkland formula is good,
yes,
but only thing is Parkland formula will not give an exact picture of burns what is happened inside. Okay, that is the only issue.
Yes. In case of burns, it's given as a formula of 4 ml per kg into percentage.
Most of the electric shock, suppose you get a hand shock, only hand will be involved. So that is a very small part of Parkland formula.
Yes.
What is Parkland formula? Percentage, how do you calculate burns? Percentage of burns.
Burns by rule of 9. Rule of 9.
Rule of 9.
Yes.
Okay.
And in myoglobinuria, we must give aggressive IV fluid correction.
Otherwise,
And
what will happen?
Acute kidney injury,
So this
renal failure.
myoglobin will go and accumulate in the kidney, produce kidney damage.
Yes. And if myoglobinuria is still persisting, we might require the presence of a fasciotomy, because patient if will be having compartmentalization
Compartment
and
syndrome.
syndromes, and or if burns is more than 20% of the body surface area due to the electric injury, or full thickness burns,
Okay.
we require fasciotomy. And disposition of the patient, usually if patient is asymptomatic patient with a occurred electric shock from a voltage less than or equal to 240 volt, we can be discharged home directly from the ER. But if patient is symptomatic, we need to admit. If patient is asymptomatic but still having an exposed to a shock more than 600 volt, we need to admit the patient.
Anything else you want to add?
Mostly that electrical injuries which you are seeing here will be associated with the compartment syndrome, because it will be on the limbs, hand mostly. So early fasciotomy is advised.
How do you know that patient is developing compartment syndrome?
There will be presence of stretch pain.
Passive.
They will have pain
So
during flexion.
severe pain during passive movement that may not correlate with your inflammation at all. It may be very, very severe. Okay. You can still see the pulse, BP and all, but it will be very difficult. Pulse Doppler you can try, but better to go for fasciotomy by pain score itself. Is there any compartment pressure monitor available?
Yes.
It is there. It is available, but we don't use it routinely. That's all. It is available.
Antibiotics.
Antibiotics, compartment syndrome should we use or not?
Like in electric burns also should be.
Use or not? You tell me.
Prophylactically, yes, because it opens the skin, that is protection. If there's some any skin.
If there is a burn,
Yes.
definitely if there is a breach in the skin, like he told, antibiotic should be used, because skin is the most important barrier from any infection. But if you are breaching the skin, then there is a chance of infection, especially in ICUs, busy ICUs. So we can use antibiotic. What antibiotic you prefer?
Gram positive.
What is it?
Stuff.
Tell one drug.
Amoxicillin.
Amoxicillin, clavulanic acid, azithromycin, doxycycline, anything will do.
Yes.
Azithromycin will be a better choice.
Yes.
Okay. Thank you.
Thank you.